This is a very boring topic. I apologize in advance. I learned a few things though doing it, but this is based on the national curriculum, and this is an hour required for you. So we will try to make this as quick as possible and get you out here before the hour, but unfortunately we have to go over some of these things. So. All right, so pediatrics, one of the things that drives me crazy is that most people think that pediatric are little adults, and that is an absolute lie. Children are children. You have to treat them as children. There's a lot more things you have to do. Do not consider them to be little adults. If you are somebody who says that, please take that out of your vocabulary. This is absolutely wrong. Have an idea of how development works, how the different characteristics are from 2 to somebody who's 10, how they would react to you, how much are they willing to let you do. Just have a clear idea. I didn't go into very much detail on all these things. That'll be a pediatric side, but just have an idea of what to expect when you go on a 2-year-old versus a 10-year-old. Always support infants' head and neck. I just had a son, and I brought him down to EMS base a couple weeks ago, and he has a very strong neck and head, and I got yelled at because I wasn't supporting it, so I'm mimicking my own self. Hilton was yelling at me and telling me I wasn't supporting it good enough. So, but anyway, PAT is something that you definitely need to remember. Everybody remember what PAT is? Pediatric Assessment Triangle. So those 3 things. We're going to review it in just a few moments. It's a very important thing to remember. And then remember they could be from nonverbal to highly communicative. So your appearance. This is when you walk in the door. You immediately see how they look. Work of breathing. You can obviously tell if somebody's having a hard time breathing as a kid. And then circulation. This is something, as far as circulation goes, that you probably need to get closer, but you can at least tell through the skin whether or not somebody's perfusing real well. So, examine on parent's lap if necessary. Get down to their level. This is an important tool that they tell you. Have a parent assist, and then be patient. Be flexible with them. Give them time. One thing that definitely don't want to do as far as transport goes, might not affect everybody in here, but want to make sure that we're putting them in appropriate equipment when we transport them. We are very much guilty of that at Person County EMS. We do not have the proper equipment. That is on the to-do list July 1st, is to purchase specialized equipment to restrain these kids. We were putting them in car seats and stuff that just, not a lot of training was involved in that, but having mom hold them on the lap is not good. That's the old EMS way of doing things, and that's not the proper way. Remember that the head is a little bit larger. Infant anterior, posterior fontanelles are open. Little soft spots on the head. Be wary of those. They can tell you a lot of things. If they're sunken in, what do you think that means? Dehydration. Yep. Kids dehydrated. If they're bulging outward.
High blood pressure or something going on?
Well, it's related to high blood pressure. There's some type of cranial problem. The brain is swollen up, so that might have been a fall down, hit their head, and now the brain is swollen, so they're bulging out. So those are the important things to kind of pay attention to when you go on these little kids. Shorter neck, smaller airway, epiglottis is long and floppy, and then we don't want to try to avoid hyperextension. We know on adults we have cardiac arrest or whatever the case may be related to airway. What do? We send that thing way back, right? What are we going to do for kids to help try to avoid hyperextension? Anybody remember back?
I'm in neutral.
Neutral works.
Neutral.
Well, what's a good way to put them in neutral? The piece of equipment you want to use. Towel. That's exactly right. Towel right underneath the shoulders, puts the head in a nice neutral position. Then you got to worry about it. Remember, small and tight volume. We're all getting very excited on cardiac arrest or anything related to that. What do we do with that bag? We squeeze it really hard. We want to make sure that we're only squeezing that just a little bit. Very high risk of foreign airway body obstruction, so we want to keep that in mind. They use their diaphragm during inspiration. Again, we have fatigue a little quicker, so we want to be wary of that, especially when we get a kid that's compensating but not compensating well. Pulse rate is what you want to rely on. One thing to always remember with kids is they don't compensate well. So if you start seeing a fluctuation in the heart rate, that is your sign to know that there's something wrong with that kid and the kid's not going to do well. Usually you're going to see it go up very quickly, and then once you see it start heading downward, you're behind the 8 ball. So it's important to watch out for that. We know that kids don't compensate well. Injured children be in shock and maintain blood pressure. If you remember years ago, blood pressure was not something we checked in kids. Most people kind of just had the cuffs in there because the state required it. We didn't really worry about it. There's really been a big push in the last few years to make sure we're checking blood pressures on kids and kind of keep an eye on that. Obviously, heart rate's what we want to rely on, but we still want to try to get blood pressures. Obviously, we don't want to be doing it on little kids, but on your average, 1+-year-olds. And then hypotension, just not something to really rely on. So don't freak out if you get a blood pressure of like 60/40 on a little kid. It's just not something to rely on. Oops. Damn. Organs are situated internally and relatively large. Again, remember that the liver and spleen can extend a little bit below. Good thing with kids is they are really good at falling down and not breaking anything because everything's so flimsy and flexible. But with that being said, we got something that's two things that are very important that can sometimes be extended a little bit below that. So we still need to be worried about injuries on that end if we do get kids that fall or whatever the case may be with it. Growth plate fractures, want to be wary of that. You end up having kids that won't have any growth if that is damaged, and that's something important on our end when we're going and using an intraosseous needle to deliver medications. And then, like I said, their ribs are more pliable. You push on them a little bit and they won't break. So. Okay. Limited stores of glycogen and glucose. Important to keep an eye on glucose in little kids. Where we want to check a sugar on a little kid? Where's the best place to prick? Foot, yeah,
Heel.
toe, and I don't know how well I would want to do this, but I've also heard earlobe. I feel like that might be a little painful, but go towards the toe. But kids use a ton of sugar, so we want to make sure we're watching out for that. Newborns lack the inability to shiver, so we want to watch out for cold with them. We want to make sure we're covering them up, keeping them warm, and of course keep everybody warm during transport. It's important. I don't know where the spot is for this thing. Okay, assessment, adapt your assessment skills, make sure we're different adults. What's the big difference? I'll give you hints on there.
Wait.
Nope.
Impatient.
Toe to head.
Yeah.
We're going to start down at the feet, we're going to move our way up to the head. Doesn't give us that direct in the face for little kids. We want to start below. Remember our PAT? I'm terrible at this, but estimate their weight. If not, guess who? Just ask mom and dad how much you think they weigh, but that's important. That's one of the first things I always do on pediatric patients, just because if shit hits the fan, I know it. I ain't got to sit there and guess it later. 10 pounds, okay, let me do my little calculation real quick. Bam, I'm ready to go. Have age-appropriate equipment. We don't want to be using adult BP cuffs on little kids and things of that nature. So, child abuse and neglect can be any of these: physical, sexual, emotional, just neglect in general. Things we want to be watching out for. We are mandated reporters in the state of North Carolina. One thing I don't like about this state that I really like that New York had was, unlike here where you report to social services, back in New York there was a 1-800 number. It was centrally located in Albany. You called it and they took care of the rest. You reported everything. Now you have to go to social services. I feel like it's just more of a pain, but I guess North Carolina hasn't caught on yet. So. Trust your instincts with this. Look for your red flags. Be alert for history that's inconsistent with clinical presentation. Document clearly what you're told. You guys fill out reports, or at least you should be filling out reports, so it's definitely important that you fill out the same and document well. Same with our guys. Get the police involved. Remember, we are obligated ED staff if you go with them, and then follow your local protocols, procedures. We have a policy that's required by the state in the general statute that we are to call the sheriff's office at night or weekends or holidays, and they get us in touch with the on-call social services person, worker, whatever. I don't know what their technical name is, but I don't like to be rude because I know they call us ambulance drivers. So, but Otherwise, during the day, we just call down there and we talk to whoever's working that day. And that's our procedure, which would fall underneath the same thing for you guys if for whatever reason you had to do it and our guys didn't get the chance, or you also wanted to call and voice something. So, SIDS, sudden unexpected death of an infant under 1. When they do an autopsy, everything looks good. A lot of factors in this that you want to keep an eye on for. Obviously, one of the things that you need to remember is, although we respond to 911 calls, a lot of our job is education. So if you're on the scene somewhere and you see something that's concerning, you might want to take care of it right then and there. So premature, low birth weight, young maternal age, sleeping prone with soft, bulky blankets, and exposure to tobacco smoke. Taco smoke. But the big one is the stuff in the crib. I've recently gone on a couple of these on the medical examiner side, and in both cases, that was the problem. It was that bulky stuff in there, and that's what the medical examiner ended up saying. So thank you. That's what the medical examiner ended up saying was probably the cause of the problem, other than they had some other factors. But if you see something like that, education is very important, very big. Geriatric population, because I think Greg told me when he was doing the stuff for the budget that like 50% of Person County population is over 55 or 65 or something like that. So I'm having difficulty here, Chase.
Not able to switch it?
Nope. There we go. So fragility is a better indicator of risk than the age of years. Polypharmacology is common, a lot of drug interactions. So polypharmacology basically means that these people are on tons of drugs. So we want to be concerned about potential interactions. Although most of them are accidental, we have some overdoses. I had a lady one day who was supposed to take prednisone, and if you know prednisone, you're supposed to take 6, 5, 4, and down the line. Well, she took 6 of her blood pressure medications. And so, that's a concern. It's accidental, but that's a concern. Age-related cognitive impairments, so we're talking about dementia and Alzheimer's and stuff like that. The biggest thing here is the loss of independence. If you've gone on calls before, you get some of those elderly folks that need the help, but they adamantly tell you, don't call my son, don't call my daughter, don't do this. It's because of the independence. They don't want to lose that independence of being at home. And so trying to find ways to get them what they need without having them jump to that conclusion is definitely difficult. And then reduce uptake of certain medications. I haven't seen it a lot here, but back when I worked in Durham, it was a ton of, well, I can't afford it. It's either I put food in my mouth or I take my medicine. So that's some important things to keep in mind on as well. I guess my battery must have died.
What kind of battery?
AAA. May feel useless or unproductive in society. Might feel mourn or feel frustrated over their loss of ability to do things, and then may have that freedom or sense of accomplishment. Any luck?
Can we roll to the next one?
Yeah, please. Again, we literally just talked about this, money issues, being able to afford the medications, afford the food. Luckily, thankfully, a lot of the pharmacies, especially like Walmart and some of the local ones, are willing to work with folks, and you get the $4 prescriptions and stuff. So it's not as difficult, but these are things that you may come in contact with to keep in mind. It puts these folks at risk. Delirium is a symptom, not a disease. Here's all the characteristics of it. Huh? I think this is the first time I've changed the battery since I've gotten it. Where should I point it?
Click that. Nah.
Sorry. So there's some of your characteristics to just keep an eye on: disorganized thoughts, inattention, memory loss, disorientation. Just remember that symptom, not a disease. Next one. Couple more things. A couple more things here to keep an eye out for: mimics, intoxication, drug abuse, some type of psych disorder. And really what you want to pay attention here is for these 5 things. If you have somebody who has that loss of consciousness or just not oriented, have vital sign changes, temperature, blood glucose, any medications, this might be a reason to have that symptom of delirium. So just keep those things in the back of your mind when you're working on stuff like that. I don't doubt you'll ever remember this, but I thought it was cool, so I put it in here, just what the delirium means, for the reasons why people are delirious. So it basically spells it out for that. So if you remember any of those, what they all stand for, I think most of them are make sense, right? Drugs causes you to be kind of loss of consciousness. I think a big one that obviously we probably watch out for a lot in EMS is eye infection, right? A lot of, we know UTIs and the elderly end up just having altered mental status. They may not have anything more than that. So just things to keep in mind in the back of your head when you're doing your assessments. Onset is usually abrupt, usually hours to days. That's what makes it even more obvious, because we know that there's other things that take over time. So this is somebody's fine, and all of a sudden over the next few days or a couple hours, they end up start having those signs and symptoms, and so that's stuff we want to look out for. And then usually once we treat it, like, for example, a UTI, they get antibiotics, everything's great. Everybody goes back to normal. Dementia, obviously one to keep in mind. You have a lot of this going on. You have irreversible brain failure, all the different signs and symptoms. You guys all know this. You've seen this before. I'm not going to read them off. You know what this looks like, and you have seen this before. Six to 10% of the elderly eventually will have dementia, and then obviously as you get older, that risk increases. Although it seemed a little low to me, I thought it was still a pretty high number for at least the group, because you got to think about how many elderly we have in this country versus that 10%. So I thought it was still a pretty high number. The way to get diagnosed is you end up having to have 2 or more of these symptoms, and they'll diagnose you with it. So I thought it was an interesting thing to see how long it actually takes. This is not something that you walk in the door and they're like, okay, you have memory and language problems, you have dementia. It's a long, drawn-out process of doctor visits and stuff to get diagnosed with it. So, no treatment, but underlying medical problems can be worked out, infections and drug problems and stuff related to that. Most important, and I'm sure if you've gone to the hospital or anything along those lines, or even your own doctor, I'm sure you've been asked this question before, is you ever go to the scene and they're like, he's not acting right. And you get to the hospital and it's like, hey, he's not acting right. What's the first thing they say? Well, what's normal? So we want to get a baseline for these folks. We want to find out what is normal for them. Talk to the caregivers, talk to people on the scene, whoever knows this person. Find out what is normal for them. This way we can see what it means to be altered. It could just be normal. Ask about new changes that prompt the call, and be cautious with patients. Dementia patients like to hit, or like to attack. So
It's the only time I almost got slapped.
So be very cautious with that. Elderly abuse is another thing to look out for. We are required, again, to report this as well. So this is just something to keep in mind. Any form of mistreatment basically includes all the ones we talked about before, but this also includes financial. So meaning you get somebody, son, daughter, grandchild, whatever the case may be, that's getting the money for that person and then not giving them all of what is theirs, or not allowing them to purchase things that are necessary for them. Abuser is almost always known to be to the abused, so this is probably going to be somebody that knows them. It's not just going to be some random thing or some type of kidnapping like you would have with a kid. So watch out for the folks that are on the scene. Use your best judgment again with this. Some clues here: unexplained injuries that do not fit, poor hygiene, and the way they act with the person. That should probably be your biggest one, the way they act with them, if they're quiet around them, or if that person always jumps in and answers the question for them or something along those lines. Listen to the patient's concerns, talk to them about it on the way to the hospital. If stable but unsafe situation, see if the patient will let you transport. If they refuse, that's when we go back to the station, make the phone call to DSS and let them get involved with that. And then obviously if it's unsafe, just get yourself out of there, call the law, and let them come and take care of it. One thing I will tell you is a lesson learned here is that it takes months to get a response from DSS. And I'm not trying to say anything bad against them. I know they're very busy, but we've seen a lot of cases where we've reported things like this, and then they go there 2-3 months later and nothing's wrong anymore. And I just, I know it's kind of one of those things that just go around in circles, but just keep that in mind. If you do report it, don't expect to hear back the next day. Reporting elder abuse, again, required, like we just talked about. Document your findings. DSS was telling me, they were showing me the sheets for elder abuse. I think it's only a few things, but for child abuse, I think it was 13 pages of questions they could ask you. Obviously, that some things are not applicable, but just to keep that in mind, different things they might ask you. And she said, don't ever be afraid to say, I don't know, because it kind of makes the process move a little bit quicker. But one interesting thing that I found with the elder abuse and the child abuse is one of the questions, their first questions is the patient Native American? They told me that if it's Native American, they automatically by law have to notify the tribal, and then they get involved, which I didn't know anything about that, so I found that pretty interesting as well. Especially since we have some of those types of folks that live in the county, so something to keep in mind. All right, homeless and poverty. Obviously, they're prone to all kinds of different problems. This is just basic common sense. All kinds of medical conditions, mental illness, substance abuse. Obviously, the problems that we may have is lack of hygiene. They're not, malnutrition, crime, violence, being out in the heat, the cold, stuff along those lines. Lack of health care is also a big thing, obviously. They may have access to Medicaid or something like that, but we know that's a long, drawn-out process, so somebody who's living out in the streets is probably not going to take the time to go through that long process. So if they are not getting the health care that they need, this is where we're going to see them more and more often. And so one of the things that I say is that you should always know what kind of things you have in your community. So what kind of things that you can refer them to, churches, free medication, whatever the case may be that your community offers. So it's important to have an idea of what kind of services there are in or around your community, I guess is a good way to put it. Domestic violence. This is one that these next two are the ones that I learned a little bit from because I didn't know anything about. And I don't remember learning this in paramedic school, so this is now some of the new requirements. Here's your definition of domestic violence. Pattern of abusive behavior in a relationship that one partner uses to gain or maintain power or control over another person. And it can be intimate, cohabiting, dating, marriage, post-separation, post-divorce. And a little bit of numbers there. 24 people per minute are victims of rape, physical violence, or stalking. 10.7% of women are stalked by an intimate partner. And then 1 in 10 women have been raped by an intimate partner. Affects children who witness it. A lot of research out there that says that kids who witness this stuff will end up growing up and having some type of psychological or mental health disorder. There's also some stuff I read in there that was very interesting, that they say that children who grow up around domestic violence are some percentage that are likely to grow up as a serial killer. So there's tons of evidence out there that this definitely affects kids, and I know it's probably not something that we think about. We're on the scene when we're taking care of them, but just something to keep in the back of your mind. Question for you, is this child abuse? What do you think? No. According to DSS, it is. This child is being mentally abused by this situation, so just something to keep in the back of your mind for when you're thinking about reporting and stuff like that are concerned. Some domestic violence. I found this interesting. Myths and facts. She deserved it. No one deserves to be punished. You can't rape a significant other. Well, we know that's definitely true. Anybody can be raped. Teaching her a lesson. Abuse is never a lesson. I was drunk or high, didn't know what I was doing. Guess what? Just because you're drunk and high, it's still a crime. They're gay lesbians, so it's not domestic violence. It doesn't make a difference. Some of them, I thought they were like, woo! You know? A couple more here. Women are likely, just as likely to be abusers. They actually said that the rate of women abusing men is pretty high. And a lot of people are like, oh no, that women ain't doing that stuff, and it's actually getting pretty close to being pretty even. So, isolated incident, never an isolated incident. If it was so bad, she'd leave. This is a big one. This is one to watch out for here. Most don't leave. Why?
They don't have the resources, they don't have the money,
Resources,
they don't have the
scared,
family support.
money, support, tons and tons of reasons. So, you know, as much as it's easier for us to be on the scene and say, just leave them. We got to remember that in most cases, it's just not reasonable. It's just not something that's going to be able to happen. So, again, knowing your resources and knowing things out there, and there's some more information about stuff that you can keep in the back of your mind to refer these folks to. And then mental illness causes domestic abuse. It's not a mental illness, has nothing to do with mental illness. Abuser behaviors use violence and threats to establish power. The tactics are usually very much selectively chosen and purposeful. These are folks that plan out why they do the things they do. And it's impossible to appease the abuser, so no matter what that person does, they're always going to continue to abuse that person. Even if the abuser says, do this, it's going to be wrong in some way, shape, or form. And that's things to keep in mind. You know, look out for when you see those things. All kinds of different types there. I think we saw, and I think most of these are pretty common sense: physical, sexual, verbal, financial, stalking, things we've already seen before. Here's a definition. Your stalking, harassing, or threatening behavior the individual engages in repeatedly can be carried out in person or via electronic devices. I don't know about the law here, but I know in New York it was a higher class if you used the electronic device to harass somebody compared to being in person. I would think the laws are pretty similar, but I don't know. Some examples: following a person uninvited, showing up uninvited, harassing phone calls, or giving constant unwanted gifts. Found that interesting. Sending flowers is stalking. Cyber stalking, probably another thing to keep in mind. Obviously, with the times changing with technology, we have tons and tons of other ways. The one that interests me was GPS system. And I was reading that there's actually some ways of stalking to hack into a GPS and watch where they go. I mean, that's just, to me, that's just, well, I don't know.
There's too much time.
Yeah, you're not kidding. You're not
You
kidding.
can do that on a cell phone.
Yeah, I guess you can.
You
Right?
put
They
a
got that
blind
friend, find a
you put a
friend
blind
thing or something
program
on
in
there.
there,
Yeah. Crazy. Characteristics of abuser, just things to keep in the back of your mind. Usually not caused by anger management. They deny responsibility. And obviously they choose who they want to abuse. Again, not a mental illness. That's not an excuse to be used on. Characteristics of your victim: usually feel helpless, cannot leave that relationship. They feel shamed, embarrassed. A lot of times they're the ones that don't call, usually get the phone call because you're the neighbor and you're screaming and yelling all night long, and so you're the one that calls, and when you get there, everybody denies everything that's happening. Fear of their safety or safety of others. Usually if there's a kid involved, that's the reason they stay. They fear that the kid's going to get abused if they leave. Not having the resource, lack of support, and then lastly, if they feel responsible for the abuse. I found that one interesting. Blaming themselves for being abused. Most domestic violence wounds, just to keep an eye out, and if you see these things, to keep them in your mind. And they're listed from most to least. If you see face and neck, arms, head, back, butt, abdominal, which increases during pregnancy, they actually said that moves up much higher if they're pregnant, more towards the top of the list. And then genitalia, which watch out for injuries in different stages of healing. This again is related to the abuse. Coping mechanisms. minimizing, denial, rationalization, drug, alcohol, self-blame. It's kind of like the stages of death, being able to grieve and stuff like that. Prevention, screening patients. There actually is specialized training for this. If you really are interested, I can get you a link to it. They actually have classes that you can go and take online and in class that teach you how to recognize domestic violence. A lot of the resources out there I had no idea about until I started doing this. Understanding what it is, explaining what it is to the patients, and trying to get them the resources, and then of course at the end, doing what we're supposed to do, being an advocate for them, getting what they need to do and getting them what they need to in order to take care of themselves and their families. Some different resources out there to keep an eye out on. Shelters. I don't know if we have a shelter here. I'm still trying to find out some stuff related to this.
They did it one time.
Freedom House.
It's Freedom House.
And that's one of the things that actually I'm sure you all know that there's a huge narcotic issue in this country. And we're actually hoping to get some money grant-wise and stuff with that. But hopefully we'll be meeting with Freedom House in the near future to actually look at some other things that's related to mental illness, to be able to transport folks to other facilities and stuff. So that's, I'm hoping to find out more about what kind of shelters we have and resources we have in this county.
How about safe havens? It's still
Stuff like that. Yep. Crisis intervention. There's actually classes out there for this. It's a great class. It's 40 hours. It's a lot of hours to do if you're a volunteer, but it's a great class to learn the different resources in your county, learn how to recognize things, and then most importantly, how to de-escalate situations. And I think that's one of the biggest things I took away from that class, is be able to walk into a room that is, you know, people are fighting and stuff, and be able to kind of relax everybody and not contribute to the fighting.
Separate them.
Yep.
There's a group, Human Services, Person County. It's more of it started out as a group or committee, and now it's more of an email group that kind of stays connected that I was on. And they are kind of like, we're Roots and Wings and Guardian Angel and all that. They come together and discuss, and they may have a citizen who needs help, and you'll see an email blast come out from them. So if you find something, then let one of us know.
Yeah. Advocacy groups, kind of like what Brett was just talking about just a second ago. Talking to them about having a safety plan, what to do in certain situations, where to go, who to be able to get in contact with. And then, of course, nobody really wants to, but law enforcement is always a big help. They know a lot about the stuff going on and able to use the ability to separate them and get that ball rolling with that. The National Domestic Violence Hotline. This is a number that they can call to be able to get resources that are not only for this local community, but just nationalized resources. So, trafficking victims is another topic I was very surprised to see at the at-risk things. I don't know if we really have this problem in Person County, but just something to keep an eye on and think about, and who knows what goes through here. So there's a potential possibility that we do. Basically, modern day slavery, defined force, fraud, or coercion, fast growing criminal activity. We know now it is a federal crime. As of 2000, it made it a federal crime. Myths. Human trafficking is the same as human smuggling. Trafficking must involve some form of travel or transportation. Victims are only foreign nationals or immigrants, and they come forward on their own accord. Why do you think there's no numbers to report human trafficking? Because they don't come up and tell you. Some numbers here. I'm a big fan of numbers. I think it gives you kind of an idea of how things go. 600,800 internationally, and this is by a year. U.S. is a little lower, thankfully, but still pretty high.
WRL's been doing a lot about human trafficking.
Oh, have they?
Yeah, I mean, it's been recently, it's been a lot more on that.
Some common observations in the form of sex trafficking, street prostitution, exotic dance bars, Latino cantina bars, I'm not sure what those are, but Asian massage parlors, escort services. I don't know if we have any of those in Person County, but
Well, it's a big problem in the Hispanic population.
Yeah.
Especially with the illegals, because they use that against them to put them into sex trafficking.
Good to know. Labor trafficking, using adults and children for labor force fraud and coercion. Commonly observed forms of labor trafficking: domestic servitude, industrial cleaning, construction, peddling and begging rings. Some portrait of the victim to kind of keep an eye on and think in the back of your head: living in a workplace or with an employer, so somebody who lives on site or lives with the employer. House with multiple people, long hours, little pay, no identification, travel documents like you're talking about the Hispanic population, children not in school, and then physical signs of abuse. Other stuff to look out for: bruises, as we continue to say, scars, urinary difficulties, pelvic pain, pregnancy, any type of chronic related back pain, cardiac related, respiratory problems, poor eyesight, malnutrition, disoriented, confused. And they say a lot of that's a result of the daily abuse and culture shock that these folks go through. Connecting victims to help, again, another national resource. I'm sure we don't have much resources here in Berkshire County, but if you end up going on and coming in contact with them, there's a national call center. They're 24/7 that they can get these folks the help that they need. And the cool thing is they'll tell you right over the phone whether or not, yep, you got somebody who's having trafficking problems. Here's what we can do for them and get them the resources that or whatever they need help with. So probably not something that we'll be able to handle here. It'll be something that they'll have to go probably towards like Raleigh or somewhere that can get them what they need. So some other populations here real quick. Bariatrics. Guess what? This is becoming more of a reality every day. We've actually been discussing the potential possibility of our next ambulance being a bariatric unit, just because we don't no longer have WAS here anymore. So our only resource at that point is if it's somebody that big, we have to call another county in. And that gets hours or that we could be wasting. So obviously every organ's affected. A lot of medications, medical conditions that we're going to see with these folks. And then obviously I think the biggest thing I take away out of all this is logistical things. You're no longer just taking care of this person medically. You need to figure out how to get them out of the house or how to move them. And so now you're kind of playing more of a air traffic controller type person, being able to get the help you need to get in there. Assessment challenges. They actually say they keep them on their side, upright as much as possible. Listen to lung sounds on the back near the scapula. They say it's the least amount of adipose tissue. I didn't know that myself, so in case you're having a hard time listening to lung sounds on these folks. Assess for cyanosis around the lips and eyelids. Heart tones on the same type deal. The heart shifts on that left side, so you'll be able to listen if you're listening to heart tones. BP cuff, we're probably going to be going either large adult or thigh cuff. And I know we don't have any thigh cuffs at EMS, so that'd be something that we get a bariatric unit that we'd have to purchase for that purpose. So just because you don't use them in it as much. And then lastly, avoid putting electrodes on the abdomen. There's too much of the tissue to be able to get that electrical connection to get an EKG. So that can pose a problem if you get somebody who's really big. The wires might not be long enough to get a reading. Airway management obviously is going to be a hell of a challenge to with all that extra tissue and weight. These guys don't have that extra reserve like we all do, so they're probably not going to be able to tolerate being apneic for a while. And then another interesting thing here is to make the mask ventilations easier, ramp up the patient's torso and head by using stacks of folded blankets and towels that are elevated at least 25 degrees. That opens up and gets that weight off the chest to be able to get that good chest rise. IVs obviously going to be difficult. Medications, they say that they could be cleared more or less rapidly depending on the medication and depending on the size of the person, so just keep that in mind because of that renal blood flow. Obviously we ain't putting them on backboards. won't be able to grab the thing and do it. Our scoop stretcher can carry upwards of 350 pounds, and that's max. Our stretchers, I don't think we have any 750s. I think ours is 500. And when they say 500, they mean 500 at mid-weight, not 500 all the way up. So that's another thing to keep in mind. Know what your equipment can handle. Keep an eye on that before you go put somebody on something. You're not going to be able to mobilize these folks. You're not going to be able to get a collar around them. You're going to have to make shift, make do with whatever you have to do. And then again, logistics. Trying to get them on the stretcher or calling for resources to get them on there. I think not long ago we had somebody in Hurdle Mills District. I think they ended up having called Durham County into transport. I think it was a while back. Maybe it was ours. Just sent us. We had to call somebody because there was just no way to be able to get them on the stretcher. And then obviously use help to get out of there. We've had in the past where I've worked, we've had to cut doors off. I want to say somebody told me that somebody had to cut the side of a house off here once.
Cut
Yeah.
the wall out.
Yeah, or something like that, to be able to get somebody out. So, you know, just that logistics there, and then they also have to take care of the patient for that amount of time to get those logistics there. So, some actions and considerations. Remember that in most cases, a lot of these folks are probably going to be unreliable historians, so you're not going to get a lot of what you need to out of them. You know, pediatric obviously is not going to be able to tell you, and then, you know, I'm sure you get it. You go to geriatric, what's one of the things they tell you? I take so many damn medications, I don't know what I take. I just take them. My doctor told me to take, here's the bag. My doctor told me to take them, I don't know. Difficult to rely on like I said, all their medications, and try to rely on their caregivers if there's somebody there to take care of them. Proper interpretation of the patient's verbal, nonverbal communication. Keep an eye on what they say, how their facial expressions are, and then watch their environment. Obviously, how they react with others. That'll be able to tell you a lot of, you know, if we're dealing with domestic-related things, trafficking, things like that. Treatment all together. Again, provide supportive care. Treat as you find. Document properly, and then know whether or not you're mandated to report. Those are the North Carolina General Statutes for EMS personnel, again, for requiring child abuse, and then abuse of adult and disabled. So again, we had to make policies on that because of that requirement by the state. And that's it. Any questions? Try to make it as interesting as possible and not as bland. I learned a few things doing it, so, but that's all I have for you. Our next Con Ed is we have 2 in July. Next one's at Triple Springs Fire, seizures, and then I think that's July 6th, and then July 20 something or 20, it's CEPO, and that's a 2-hour one, so there's 2 topics for that. And then again, like I said, if you're interested, write your name down. That'll be the pediatric. You have a whole month to do that. So I haven't figured out what I'm going to do for August. I'm trying to research some of our guys, so I've been picking topics that what they need. Because with all the state changes, a lot of them got screwed. Basically, it's the easiest way to put it. So I'm trying to catch them up on some of the requirements. So, but as you know,
I do know.
Yep.
Can you summarize the changes that's coming with EMT, the requirements, the education with this switch up?
Yeah, so if you got your certification before 2014, you have to take a transition course. Depending on where you take it, it can be anywhere from a few hours to, if you take it online, I think they go up to the max, which is 24 for EMT. Basically, what I've been told by a lot of the older timers is it kind of brings back old stuff. They have simple rebreathers and venturi masks and all the things that were used back in the old days, simple face masks and stuff. To recert now, as of actually as of July 1st, anybody who expires after July has to do 80 hours. There's a national, local, and individual requirement. So it's basically broken down of the 80, so I want to say it's 40, 20, and 20. 40 is on the national side. The national is stuff that's gonna change every 4 years from the National Registry. It's all about what is the kind of the big topics in EMS. If there's a problem with something, they'll make that change. And then local is kind of a mix. We require a certain amount of medical, a certain amount of trauma, a certain amount of peds, a certain amount of operations. And those can be very broad topics, just has to be within that category. And then your individual is 20 hours and whatever you want it to be.
And that 80 hours is per year?
4 years.
Okay.
So your 4-year
So
certification.
20 a year.
Yep, basically it'll be.
But it has to fit those 3 categories.
Mhm. That's the biggest challenge.
Yeah.
that
And
we
you're gonna
found.
be overseeing that for us volunteers?
Yes, so like I said, I have a chart, and you guys got the stuff in your departments. If you come to all those con eds plus, or at least try to come to all of them, plus do the online thing, you should have no problem researching.
What about that, I don't know, the class, that 8-hour class we have to take?
The transition
The
course?
transition, when you'll do another one of those?
Probably gonna look to do it in the fall. Probably look at, I have to go to Maryland in September for work, so I'll probably look to do it October maybe. And these guys took it last, it's 8 hours, since I'm being recorded. But you're
Good 8 hours.
so, it's, most of the, if you honestly look at the transition stuff, most of the stuff that is on there is stuff we do. I mean, like, auto injectors, AED.
A lot of it actually doesn't even like apply.
Yeah, I mean, we don't do auto injectors anymore,
Yeah.
because the damn things are $300, $400, so that, but that's the stuff that's included, so a lot of it I consider review, and it's just easy Con Ed hours. That's really more what it was than anything, so. But you're more than welcome to take it online.
I would highly suggest, the spring wasn't a good time for us, so I'm hoping for the fall. But in
got some
October,
requests.
when's our stew? Don't do it on that Saturday.
Third Saturday of October.
Yeah, don't do it on third Saturday, October.
Okay.
Just telling you, if you're setting it up to
Just
do it
remind
out,
me.
just don't do it on
I
the
mean, I
third
don't mind,
Saturday
we
of
can do
October.
November, you have until technically 2018, the end of 2018 to do it.
Okay.
So you don't have, if you don't get it this year, you don't have to stress, but I did get a couple requests from some other folks in other departments asking to do another one in the fall, so we'll pick a time to do it, so we'll get it done. It's not hard. Hey Blake, remember you got 24 hours of Con Ed to that. I know you had to write a paper, but you got 24 hours.
I want to tell you, I took that thing twice. I missed it by like 2 points the first time on that damn essay. I did it the second time I got it. I hadn't wrote an essay, man. I graduated so long ago, you wouldn't believe it. You know,
It only had 10 grades in it.
that's right. They didn't have a 10. But I got it the second.
You know, that was the first question everybody asked me when I was putting it together. Are you gonna write an essay? Yeah, you gotta write an essay.
I can't even spell.
Like I said, it's no, and honestly, the only reason I think they probably did the essay was for the hours, to get you extra hours. But I'm guessing you would have took the 8 hours and said hell with it.
Oh, yeah. I sure would.
But,
But I mean, as far as everything else was fine. It was a good review and covered a lot of topics. But
Yeah.
I thought I was doing it right on the first time I did the essay, but I missed a whole lot of. I did something wrong.
they got a little, when I took it years ago before it was a requirement, they were a little easier on the essays. Now I think with the amount of people coming in, there, the state's watching, so you got to be a little harder grader than what it used to be. But
And the reason for all of this is taking us to National Registry 11.
so what I was told by the state was that the reason they did this was because every state has looked to make it a standardized approach. When nobody here is going to become National Registry by taking this class, you still got to go through all the National Registry motions in order to get that. This just is all he said. Again, I'm being recorded, so I probably should watch what I say, but he said word for word was, all we did was adopt a piece of paper that said National. That's it. So, again, I mean, like Miranda's, she's going through the research right now. We're trying to fit hours into different things, and some stuff I can be flexible with, but stuff like at risk, we can fit pediatrics, bariatrics, if you take a bariatric class, stuff like that, but, you know, your son's trying to get the evidence-based guidelines. Like, that's a hard topic to really do, so we use peer review and stuff on stuff like that. Or if you go to a policy change, or actually very near future, one of the things I might do is pick a day, we're gonna do protocols. The state pushed out new protocols, so I just finished updating them. I can tell you right now that there's probably no change on the BLS side. It's more ALS side that there's changes, but we can come in here, start talking about stuff. The other thing I want to do, I don't know if I'll do it this year, next year, is do call audits. So one of the things we do is every quarter we have peer review call audit. We pull PCRs, good, bad, whatever the case may be, and we just come in and talk about them, discuss them, and, you know, try to find ways to improve. So that can count towards your evidence base and stuff like that. So and that'll require me to try to get, you know, I guess I'll talk to the chiefs and stuff, try to get your actual reports so we can actually look at them.
That's how peer review got started, but it kind of
Veered off.
Yeah, where you would have the fire report, 911 report, fire report, EMS report, because I think Brent was serving as the county.
Yeah.
I'd love to get back to that. The problem is that I just have never, he doesn't come, and so one of the things that I would, you know, without trying to cause problems is, you know, try to get a, no offense to him, but try to get a representative from the county fire that can come during the day when we have them. Because it'd be nice to actually have, you know, we're supposed to have, you know, you guys come communications, we always communications, we're supposed to have a city fire representative, or county fire representative, we're supposed to have the hospital, we're supposed to have quite a few different things, and the hospital's got a lot of, you know, turnover right now, so we haven't had the hospital there in a while, so it's been difficult, other than all of us just sitting in a room talking about our own calls, not having any outside look on things, so.
Well, 83% of us are volunteers.
I understand.
That weren't normal jobs.
Yeah.
I
Much during
understand.
the
I
day.
totally understand
It's
that.
like the
That's a-
county having First Responder Appreciation Day at 12 noon on a Wednesday.
I totally understand. So that's why I'm saying, if
I mean, that's, let's put the abuse back up there. I think
You're retired, come on.
Retired, hell.
So that's why I would like to do some type of something like a peer review on one of these nights, where it's
Be a
more
good
more of a discussion and actually able to get your reports and see what your reports say, and then compare them to the EMS report and stuff like that. So I think it'll be good. But I try to make things work. You know, I know people work jobs during the day and stuff. So, but if there's somebody who's retired that wants to come and chill out with us, I'll buy you breakfast that morning or something, you know, whatever gets you there. But you got it. You ain't got no excuse.
He didn't buy me breakfast.
Makes a difference if you get paid to go.